Welcome to the deep dive. Today we're really getting into the weeds. Think of it as a high-stakes consultant-level Viva.
Right.
We're assessing the core evidence, the guidelines, everything that governs how we manage peripheral vascular disease, specifically CLTI and intermittent claudication.
That's the plan. We need to go beyond just the headlines today. We're pulling out the critical high-yield knowledge from, the GVG, the ESVS guidelines, those landmark trials. This isn't just academic. It's about taking that complex data and making it work for patient care right here in UK practice.
Exactly. And we've picked 5 key areas we really need to nail down. We'll be hitting WIfI, staging why the name change matters.
Okay.
Then the whole issue around early revascularization and claudication, is it safe long term? After that, BASIL 1, its findings and how relevant it is now.
So crucial.
Then the Paclitaxel device controversy, sorting fact from, past fear. And finally, amputation, the tough numbers, and what our health system needs to do.
A full agenda.
Right, let's kick off with classification. Okay, let's unpack this straight away. We've moved on from CLI, critical limb ischemia. That term felt a bit broad sometimes. First up, can you give us the precise definition of chronic limb-threatening ischemia, CLTI?
Sure. So CLTI is fundamentally a clinical diagnosis, a syndrome. It's specifically defined by having peripheral artery disease, PAD, obviously, combined with either ischemic rest pain needing regular painkillers or gangrene or a lower limb ulceration that's just not healing after more than 2 weeks.
Okay.
And that precision is key. It filters out other causes, trauma, venous ulcers, acute emboli, things that aren't chronic PAD. It focuses us squarely on severe PAD requiring urgent vascular input.
Right, got it. And the system we now use globally to stage how bad the limb actually is.
That would be the SVS WIfI classification, came out in 2014. WIfI stands for wound, ischemia, and foot infection. Exactly. 3 separate axes, each graded independently. Its strength is that granularity. Older systems like Rutherford, they often lumped quite different clinical pictures together. WIfI grades, wound, ischemia, and infection severity, mostly on a 0 to 3 scale.
Okay, let's focus on that I for ischemia because, so many of these CLTI patients have diabetes, CKD, medial calcification is everywhere, which makes the good old ABI, the ankle brachial index, pretty unreliable sometimes, doesn't it? So how do we actually measure perfusion accurately for the WIfI score? Does SVS really expect us to do things like toe pressures routinely in a busy clinic?
Yeah, that's a really important point and probably the trickiest bit of the eye. You're absolutely right. Calcified arteries often give a falsely normal ABI, 0.9 to 1.4, but the patient has terrible distal disease. Some studies, particularly in diabetics, showed relying just on ankle pressure misclassified, over 40% of CLTI limbs.
40%, wow.
Yeah. So the WIfI system strongly pushes for objective testing with toe pressures, TP, or maybe transcutaneous oximetry, TCPO2, when you suspect calcification, or the ABI just doesn't make sense.
Right.
And the reason is predictive power. The data shows a TP below 30 millimilli Hg, or TCPO2 under 10 millimilli Hg. These are much better markers of, truly inadequate perfusion. And they correlate much more strongly with the 1-year risk of major amputation. It adds a step, yes, doing MPs, but it gives us the functional data we need.
Okay, so we assess wound, ischemia, using these more accurate pressures if needed, and infection. You grade all 3. What does putting those grades together actually tell us for the clinician, for the patient's outlook?
Well, combining those 3 independent scores gives you 4 distinct clinical stages, WIfI, stage 1 up to stage 4. And these stages aren't just labels. They're pretty powerful prognostic tools. We've got data now on, I think, nearly 3,000 patients showing these stages correlate really well with the big outcomes, risk of major amputation, and also time to wound healing.
So a stage 4 is significantly worse off than a stage 1.
Massively different. A WIfI stage 4 patient, think major tissue loss, maybe wound grade 3, combined with critically low toe pressures. Ischemia 3, they might be looking at a 1-year major amputation risk, easily over 50%. Compare that to a stage 1, maybe just rest pain, no tissue loss, much lower risk.
Right, that clarity is vital. Which leads us nicely into treatment planning. How does WIfI fit into the bigger picture, that plan paradigm we hear about?
It's absolutely central to PLAN. Remember, PLAN stands for patient risk, limb severity, and anatomic complexity. It's the framework for guiding evidence-based revascularization, or EBR. WIfI gives us the L, the limb severity score. But you need the whole picture.
In the EN, the anatomic complexity.
That's where GLASS comes in, the Global Limb Anatomic Staging System. GLASS stages the anatomy of the disease itself, looking at the inflow and outflow vessels, grading complexity from stage 1, which is simple, up to stage 3, which is highly complex, often multi-level disease.
Hang on, let's just pause on GLS for a second. How does it measure that complexity practically? Can't we just eyeball the angiogram?
Well, GLASS gives it structure. It forces you to score specific things like how long is the occlusion, how many tibial vessels are involved, is there heavy calcification, what's the state of the pedal runoff. It standardizes that assessment.
Okay.
So you might have a patient with a really high WIFI score, say stage 4, terrible tissue loss. But actually, anatomically, it's a low GLASS stage, maybe just a short focal popliteal blockage that's easy to fix endovascularly.
Right.
Or the opposite of patient might only be WIFI stage 2, maybe a small ulcer, but their GLASS score is 3, looks like concrete, from groin to ankle, all 3 tibials gone. That's a very different challenge.
And how does that WIMIF-class combination guide the actual intervention choice, according to the guidelines?
The global vascular guidelines suggest a kind of matrix.
Yeah.
If you have high limb threat, so a high WIFI stage, and high anatomical complexity, a high GLASS stage, then the most durable revascularization is needed. That usually means bypass surgery with vein if the patient's overall risk, the P in plan, allows it. There's data showing if you try endo alone for those really complex high WI high GLASS patients, the amputation rates can be pretty high, maybe approaching 20% in some series. It shows the limits of just angioplasty in the toughest situations.
So this standardization is really the key. WIFI gives that multidimensional risk profile of the limb itself.
Exactly.
Which then feeds into plan, alongside GLASS for anatomy and the patient's overall fitness, guiding how urgently we need to act and what sort of intervention complexity is warranted.
Precisely. It means a vascular unit here in the UK can talk the same language about prognosis and treatment strategy as a unit anywhere else. It helps ensure we're attempting limb salvage appropriately based on the actual level of threat.
Okay, that provides a solid framework for CLTI. But now we need to switch gears completely to managing symptoms in intermittent claudication, where the stakes, well, they feel different, don't they?
Absolutely. Different ballgame.
Let's take a classic case. Say a 60-year-old, still working but a smoker, comes in with genuinely disabling claudication, maybe can only manage 100 meters. Angio shows an isolated, short SFA occlusion. TASA-C, maybe B. Technically, fixing that endovascularly is straightforward, quick symptom relief. Tempting.
So how do we justify sticking to the gold standard conservative approach? How do you convince that patient who just wants the pain gone that doing nothing invasively, at least initially, is the right thing?
It's a conversation we have all the time.
Yeah.
The absolute cornerstone for IC is non-invasive management first. That means best medical therapy, BMT statins, antiplatelets, BP control, smoking cessation, plus structured exercise therapy. That's a Class I, Level A recommendation. Strongest evidence possible.
Right.
And we stick to that because fundamentally IC is a symptom of systemic disease. It's not usually a threat to the limb itself. Okay, but we need the numbers to back that up because patients often don't feel it's benign. What's the actual long-term prognosis for the limb if we just manage them medically?
The limb prognosis is remarkably good, actually. Recent good quality prospective data shows the chance of someone with stable IC progressing to that severe CLTI stage we just discussed is incredibly low. It's only about 1.1% over 5 years.
1%. That low?
Yeah, 1.1%. And the risk of needing a major amputation if they're managed well medically, even lower, around 0.2% over 5 years. Almost vanishingly small.
Okay, 0.2% amputation risk.
So that immediately reframes the risk. The patient is far, far more likely to have a heart attack or a stroke or die from their systemic cardiovascular disease than they are to lose their leg because of the claudication. Our priority has to be tackling those systemic risks first. The leg symptom comes second unless it's truly ruining their life despite best efforts.
That context is crucial. But let's tackle the tricky bit, the potential downside of intervening early. There was observational data, Golledge et al., back in 2018, I think, suggesting that jumping in early with revascularization for IC might actually increase the risk of needing more procedures later, maybe even progressing to CLTI or amputation. How can fixing a blockage make things worse? Or is that just bad data?
Yeah, that Golledge paper certainly caused a stir. It's paradoxical, isn't it? But it needs careful appraisal. Observational studies like that one do suggest that early intervention for IC correlates with a greater long-term burden, more re-interventions, maybe higher rates of CLTI, even limb loss down the track. It points toward that risk of iatrogenic harm, starting a cycle of procedures.
Okay, let's critically appraise that. You mentioned observational data. What about confounding by inpatient? Could it be that surgeons were just choosing to intervene early on, patients who already had worse disease biologically, even if the lesion looked easy? Patients destined for trouble anyway?
That's exactly the weakness of observational studies. Confounding by indication is highly likely here. A surgeon might be more inclined to offer early stenting to someone whose walking distance has plummeted rapidly, suggesting a more aggressive underlying disease process, even if the SFA lesion itself looks simple on the scan.
Right, so the patient was maybe on a worse trajectory to begin with.
Quite possibly. That patient might have been inherently more likely to fail conservative measures in progress, regardless of what we did. Then, the early procedure maybe fails prematurely because the disease is aggressive, leading to restenosis, needing more procedures, maybe throwing off some debris distally, and suddenly you've complicated things. So yes, the study design is prone to bias. But the signal isn't isolated to just that one study. Multiple registries hint at this long-term trade-off. When we intervene for claudication, we are potentially committing that patient to lifelong surveillance, repeat procedures, managing restenosis, things they might have avoided if we'd stuck rigidly to conservative care first.
So even if the immediate result of an angioplasty or stent is good symptom relief, we're potentially trading that short-term gain for a significant lifetime burden of follow-up, reinterventions, potential complications, all weighed against that tiny 0.2% 5-year natural risk of amputation.
Precisely. It's short-term relief versus long-term durability and the generally benign natural history. That's why we must follow the stepwise care approach. Revascularization is only for patients with truly lifestyle-limiting symptoms after they've failed a proper dedicated trial of BMT and supervised exercise, usually at least 3, maybe 6 months.
Got it.
The decision has to hinge on their functional impairment and quality of life, not just because we see a blockage on the angiogram that looks technically straightforward to fix.
So the core message for IC, conservative first, is mandatory. The limb's prognosis is excellent naturally. Early intervention, while tempting, carries a real risk of long-term reintervention burden and potential iatrogenic harm, possibly even worsening the limb's outlook compared to doing nothing invasively.
That sums it up perfectly. It's about patience and managing the whole patient, not just the narrowed artery.
Okay, if conservative is king for IC, we have to flip that entirely when the limb is genuinely threatened. For CLTI, intervention isn't optional, it's about limb salvage.
Absolutely mandatory.
The BASIL-1 trial bypass versus angioplasty in severe ischemia of the leg gets quoted constantly as the key evidence here, especially for disease below the groin. What were the absolute core findings from BASIL-1?
Right. BASIL-1, published back in 2005, is still foundational. It's really the only big multi-center randomized trial in RCT that directly compared putting endovascular first versus putting bypass surgery first for patients with limb-threatening ischemia, focusing mainly on infrapopliteal disease.
And the headline result, what did it find for the main outcome, amputation-free survival?
The key finding was that both strategies, endo first and bypass first, produced broadly similar results for the major outcomes. Overall mortality, rate of major amputation, and therefore amputation-free survival, AFS, when measured at 1 year.
Okay, similar AFS at 1 year.
And AFS is really the crucial metric, isn't it? It combines survival with limb salvage, no good saving the leg if the patient dies, and vice versa.
Now, here's where the appraisal gets interesting, I think. BASIL-1 used what we now consider quite basic endovascular techniques, right? Mainly just plain old balloon angioplasty, PTA below the knee.
That's right. Pretty rudimentary by today's standards.
We know PTA alone below the knee has, well, fairly poor long-term patency. Yet BASIL-1 found it achieved similar AFS at 1 year compared to vein bypass, which we know is generally the most durable option. How did those similar AFS results happen if the endo procedures were likely failing much sooner?
That's the absolute crux of interpreting BASIL-1. You're spot on. While AFS was similar 1 year, the secondary outcomes told a different story. BASIL-1 did strongly suggest that, particularly beyond 1 year, bypass surgery using the patient's own vein gave superior patency compared to the endovascular approach they used, or indeed bypass using prosthetic grafts.
Okay, so bypass lasted longer. How did the endo group keep their legs if the angioplasties were failing?
It boils down to the concept of rescue or reintervention. The likely explanation for the similar AFS, despite inferior endopatency, is that when the initial endovascular procedures failed, when they restenosed, they were often relatively straightforward to retreat endovascularly. The endovascular first group needed significantly more repeat procedures, more surveillance, more tinkering, if you like, to maintain that limb salvage status.
Right.
So the trade-off was accepting a higher burden of reinterventions in the endo group in return for a less invasive initial procedure.
Right. So durability mattered long-term, but the ability to easily bail out a failing angioplasty saved the limb in the shorter term. Makes sense.
Mm.
But that was 2005. We now have drug-coated balloons, drug-eluting stents, fancy wires, atherectomy devices, tools BASIL I didn't have. So how does that historical BASIL I data actually guide our choices for CLTI today? Are we still using it?
We absolutely are, although we acknowledge its age regarding techniques. We're eagerly awaiting the final results from newer trials like BEST CLI and BASIL II and III to give us more contemporary comparisons. But for now, BASIL I's principles still underpin that individualized, stratified plan approach. It supports the classic horses for courses argument.
Okay.
We use BASIL I's findings to help balance the expected durability of an intervention against the patient's fitness for surgery, the PE plan, and the anatomical complexity, the AN from glass. BASIL I essentially tells us, if the patient is fit and the disease is complex, bypass likely offers the most robust long-term fix.
Can you spell out those two main pathways then? Using plan stratification, when would BASIL I point towards bypass and when towards endo?
Sure. So path 1. Consider an average risk patient, someone medically fit for a big operation. They present with advanced limb threat, say WIfI stage 3 or 4, and the anatomy is complex, maybe a high glass stage 2 or 3, long blockages, poor runoff. In that scenario, BASIL I supports offering a vein bypass first. The superior long-term patency of vein gives the best chance for durable wound healing and limb salvage with likely fewer repeat procedures over their lifetime.
Okay, fit patient, bad limb, complex anatomy, lean towards vein bypass.
Exactly. Path 2. Endovascular first remains the preferred strategy for patients with less complex anatomy, maybe a lower G elastase lesion, or, very importantly, for patients who are high risk for open surgery due to significant comorbidities.
The frail patient.
The frail patient, exactly. For them, the advantage of a less invasive initial procedure, which BASIL I showed gives similar AFS at 1 year, often outweighs the fact that the patency might not be as durable long term. You accept the likelihood of more reinterventions to avoid the upfront risk of major surgery.
So the big takeaway from BASIL I, until we get BEST CLI and the other results, is that while 1 year AFS was similar, vein bypass showed better patency. Therefore, the choice today really hinges on that plan assessment, balancing patient risk, limb severity via WIfI, and anatomic complexity via glass.
Precisely. BASIL I forced us to stop thinking one size fits all for CLTI. We have to tailor the approach based on a proper, multifaceted risk assessment.
Right. Let's shift focus now to device safety. A few years back, the vascular world got, well, pretty shaken up by regulatory alerts about Paclitaxel-coated devices. DCBs? BSs?
Oh, yes, I remember it well.
This is still really important for how we practice and how we consent patients. So critically, what was the original mortality signal that caused all that concern with Paclitaxel, and what's the current evidence consensus on that long-term risk now?
Okay, so the whole controversy kicked off with a meta-analysis published in 2018 by Katsanos and his group. What they reported was, frankly, quite alarming. Their analysis suggested a potential increase in all-cause mortality, starting around 2 years and becoming more apparent out to 5 years in patients treated with Paclitaxel-coated balloons or stents in the femoral popliteal segment compared to those treated with uncoated devices.
An increase in death associated with the drug coating. That's huge.
Yeah.
What happened next? Regulators must have jumped on that.
They did, immediately. The FDA, European bodies, alerts went out, guidance was issued. It caused significant concern, understandably, among clinicians and the public. But crucially, it also triggered an intense period of investigation. People went back to the raw data.
How?
By pooling much larger data sets, specifically using independent patient data, IPD meta-analyses, which are more robust than just using published summary results. They also did detailed post-hoc analyses of the big individual randomized trials, like SFA debate and others.
And what did that deeper dive show? Was the signal real?
The overwhelming consensus now, based on that much larger and more granular data, is that the initial concern about increased long-term mortality has been largely refuted. The bigger IPD analyses, involving many thousands of patients, simply did not find a statistically significant difference in all-cause mortality between paclitaxel-coated and uncoated devices.
Okay, we're largely refuted. So just to be clear, how does the safety profile look now compared to just using a standard uncoated balloon? Is the death risk the same?
Essentially, yes. The most recent systematic reviews in these large pooled analyses show that for treating the femoral popliteal artery, using a paclitaxel-coated balloon results in similar risk estimates for all-cause mortality across the short, medium, and long term compared to standard uncoated angioplasty. While ongoing vigilance is always needed with any device, that specific mortality concern hasn't been borne out by the larger data sets. We can be more confident using them where appropriate.
Right, so if the safety profile is acceptable, let's circle back to why we'd use them in the first place. What's the benefit of a DCB, especially thinking about intermittent claudication again, where we're already trying to minimize procedural risks?
The benefit is about durability. We know standard PTA in the SFA for claudication has limitations with restenosis. Drug-coated balloons have consistently shown in trials that they lead to improved primary patency. The vessel stays open longer and significantly lower rates of target lesion revascularization, PLR, meaning fewer patients need repeat procedures on that same spot compared to PTA alone.
And that reduction in TLR is key, given our earlier discussion about the burden of reinterventions in IC.
Exactly. If we do decide intervention is warranted for severe lifestyle-limiting claudication after failed conservative therapy, we really ought to use the tool that gives the best chance of a durable result, minimizing the need for the patient to keep coming back for more procedures. The paclitaxel on the balloon helps suppress that neointimal hyperplasia, the scarring that causes restenosis.
Okay, which brings us right to the practical point. Consenting a patient in the clinic today. In the NHS, how should we handle this? Say you're proposing a DCB for a typical TASI A or B SFA lesion causing claudication. Yeah, to mention the history, right?
Absolutely. Transparency is key. You have to acknowledge the past. I typically say something like, look, a few years ago, there was a concern raised based on analysis suggesting a possible link between these drug-coated devices and mortality much later on. Regulatory bodies looked into it very closely.
Okay.
However, and this is the crucial part, since then, much larger studies looking at individual patient data have been done, and they haven't confirmed that initial finding. The current consensus, supported by bodies like the ESVS, is that the mortality risk is similar to standard angioplasty.
Then you link it to the benefit.
Exactly. And the reason we're recommending this specific balloon is that the evidence shows it gives a better chance of keeping the artery open longer and reduces your likelihood of needing another procedure on this same spot down the line. You frame it around the current understanding of the benefit-risk profile, citing the improved patency and TLR reduction. The ESVS guidelines do support using DCBs adjunctively after good PTA for these lesions in IC.
So the bottom line on paclitaxel. Contemporary evidence refutes the long-term mortality worry. DCBs are supported for use, particularly in the SFA for IC, because they improve patency and reduce TLR. But that consent conversation needs to be open about the history and clear about the current data.
That's the approach. Evidence-based recommendation coupled with transparent communication.
All right, final section. We have to confront the toughest outcome in PVD management: major amputation. It represents in many ways a failure of care. What are the truly stark figures on mortality after someone has a major lower limb amputation? And what does the epidemiology, thinking about Ahmad's work on variation and deprivation in England, tell us about how our services need to be structured?
Yeah, the figures are grim, and we shouldn't shy away from them. They really highlight how sick this patient group is. Remember, most major amputations, over 80%, are done for uncontrolled CLTI. The relative 5-year mortality rate after a major lower extremity amputation is, well, it's staggering. It's around 70%.
70% dead within 5 years. Let's just let that sink in. That's worse than many common cancers, isn't it?
Yeah.
Colorectal, breast.
It is. Significantly worse than many. And it really underscores the systemic nature of the disease. When we consent someone for an amputation, often the immediate focus is, understandably, on controlling sepsis, getting rid of dead tissue, saving their life now. But perhaps we don't always adequately convey just how poor their overall long-term prognosis is, driven by their underlying cardiovascular disease, renal failure, diabetes. It's a marker of extreme systemic illness. And it's even worse, as you'd expect, for bilateral amputees. Their 5-year survival can be less than 40%.
Those mortality rates have massive implications for health service planning. What did the epidemiological studies like Ahmad's looking at England reveal about why these outcomes happen? Are there disparities?
Huge disparities. That's one of the key findings. There are major differences in amputation rates, not just between countries, but significantly within countries, even within regions of the UK. And a major driver is socioeconomic deprivation.
How so?
PCD, and therefore CLTI, hits people in lower socioeconomic groups harder. They tend to have poorer access to preventative care. Primary care may be present later when the disease is much more advanced, turning up with severe WIFI, stage 3 or 4 limbs, established infection, tissue loss. It points to failures much earlier in the pathway and diagnosis, risk factor control, access to timely specialist care.
And does that link to treatment patterns, like the revascularization paradox?
Exactly. The data often shows a paradox where more deprived areas, despite having a higher burden of disease, may actually have lower rates of revascularization procedures being performed relative to their amputation rates. It suggests that in some areas, more patients might be going straight to a primary amputation without a limb salvage attempt ever being considered or feasible because they presented too late.
So it's not just about having skilled surgeons, it's about the whole system access, early detection, timely referral pathways. What's the evidence-based solution that's pushed globally to try and fix this?
The universal consensus, strongly advocated by the Global Vascular Guidelines and reflected in NHS planning, is the need for multidisciplinary teams, MDTs, and the organization of complex limb salvage care into specialized centers of excellence. This isn't just a nice idea. The evidence shows that where this is done well, amputation rates fall. It's about ensuring consistent, high-quality, protocol-driven care.
Okay, the MDT, we hear that term a lot. What specifically makes it work? What are the essential components, that toe and flow idea, that actually makes a difference to outcomes?
The power of the MDT lies in bringing together all the necessary expertise rapidly and coordinating care efficiently to tackle that complex triad: the wound, the infection, and the ischemia. The absolute core is what we call toe and flow.
Toe and flow.
Flow is the vascular surgery input, rapid assessment, and revascularization to restore blood supply. Toe is expert podiatric surgery or orthopedic foot and ankle input, crucial for urgent, aggressive wound debridement, infection control, and complex wound management.
Right.
But it's not just them. You need infectious disease specialists, diabetologists, specialist nurses, orthotists, rehabilitation teams, all working together, ideally under agreed pathways, to ensure nothing falls through the cracks. The flow team fixes the pipes quickly. The toe team manages the fallout and infection, preventing minor issues from becoming limb-threatening catastrophes. It drastically cuts down delays from presentation to definitive treatment.
And do we have hard evidence that this model actually reduces amputations? Specific examples?
We do. The data is quite compelling. Look at places like the Netherlands, for example. After they implemented a nationwide strategy focusing on these principal specialized centers, MDT working, they reported a 34% reduction in major amputation rates across the country.
34%, that's a huge impact.
It is. It shows what's possible with system organization. Here in the UK, quality improvement initiatives from bodies like the Vascular Society, BSGBI, have focused on benchmarking outcomes, like aiming for post-op mortality after amputation to be below 10%, driving that focus on optimizing care within these structured MDT environments.
So to wrap up this section, major amputation carries that horrific 70% 5-year mortality. Reducing this requires more than just good surgery. It demands system change, centralized centers of excellence, robust MDTs built around that toe and flow principle, specifically designed to combat the disparities linked to deprivation and late presentation.
That's the challenge. The technical skills are vital, but it's the system structure and the teamwork that will ultimately move the needle on population-level outcomes for limb salvage.
Well, that was certainly a rigorous workout through the evidence. I think we've clearly established that managing PVD, particularly CLTI, is this constant, very careful balancing act, hasn't it?
It really is. You're balancing watchful waiting and maximizing conservative therapy, especially for claudication, against the need for timely, risk-stratified intervention when the limb is truly under threat.
So the key takeaways for anyone listening managing these patients?
I think they're pretty clear. One, for intermittent claudication, stick rigidly to best medical therapy and that stepwise approach. Cardiovascular risk reduction is paramount. Intervention is reserved for failed conservative management in lifestyle-limiting cases. Two, for chronic limb-threatening ischemia, use WIfI, plan, and GLASS diligently. They are your guides to tailor the revascularization strategy. Bypass, usually with vein, is favored for complex anatomy in fit patients due to durability. Endo first for less complex disease or higher-risk patients.
Okay.
And three, remember the system matters. MDTs and specialized centers aren't optional extras. They are fundamental to preventing amputations and tackling those stark health inequalities. Teamwork saves limbs.
A really strong summary. So here's a final thought for you, our listener, to perhaps think about after this deep dive. We know from the data, like Ahmad's study, that socioeconomic status and how easily someone can access good healthcare directly links to late presentation, more severe disease, and those shocking 70% 5-year mortality rates after amputation. So the question is, how can we use the sophisticated staging tools we've just discussed, WIFI and GLSS, not just retrospectively to measure failure in deprived areas, but proactively to better resource those very communities? How do we move beyond simply documenting the problem and actually use these tools to argue for and deliver the specialized toe and flow expertise where the need is greatest, rather than just assuming patients can travel miles to a central hub? Something to ponder.